Let's Talk About Health in Africa on Utano Podcast with me, Lenias Hwenda. Today, we are talking about rare diseases in Africa, and my guest on the podcast is Kelly du Plessis of Rare Diseases South Africa. Kelly, welcome to Let's Talk About Health in Africa.
Thanks so much for having me. It's a pleasure to be here.
It's a pleasure to have you. Well, first of all, Kelly, can you take us through what makes a disease rare?
So it's a very, very good question. So geographically, some things can be rare in some areas and not in another. As an example, sickle cell disease is quite common and prevalent up in centralized Africa, whereas in South Africa, it would be considered rare. So it was one of the initial challenges that we sought to overcome, and we have now, alongside working with the organizations such as Rare Diseases International and the World Health Organization, we have managed to come across a definition which is considered 1 in 2,000. So if one person out of 2,000 people has the condition, if that's the prevalence, then it will be considered rare.
So basically, depending on where you are, a disease could be rare or not so rare, but there is a general definition that covers, all rare diseases. So how did you get involved in patient advocacy for rare diseases?
So at the diagnosis of my son was diagnosed with a rare condition when he was 11 months old. And at the time, there was very little support available to South Africans impacted by rare conditions, and we desperately needed to get him access to the treatment that he required, which was very expensive and not readily available in South Africa. So that's how the advocacy journey started. And and I mean, I'm pleased to report that he's doing really well, almost 14 now, and otherwise a happy, healthy little boy. Not so little.
Yeah, as a healthy 14-year-old, you have, your beautiful teen, but I mean, that must have been quite a journey, 11 months old, and then you had to start from scratch to get the right diagnosis. And we know that rare diseases generally face very significant inequality in terms of awareness by the health authorities, by communities, the people who are supposed to be taking care of the patients. So what was it like for you, and how were you and your peers across the continent raising awareness to change this dynamic, the struggle that families have to go through to get a diagnosis and to get to treatment?
Yeah, so I mean, the diagnostic odyssey is quite a lengthy one. Many patients, take years to get an accurate diagnosis, and one of the big challenges is that many of the rare diseases mimic common day-to-day conditions. So it's, it takes a really long time, and someone who's really intuitive to actually, separate what's relatively common from, the rare stuff, and to correctly diagnose a patient. And then once you diagnose, that's half the battle won to get your diagnosis. But then once you diagnose, the next challenge is obviously accessing the services that you need. And only 5% of rare diseases have a diagnosis, a commercial therapy available to them. So in that, you've kind of got to hope that you're one of the lucky diseases that has a treatment, because alternatively, all that's available to you is supportive care. And that's very difficult to advocate for in itself, because there's nothing really anyone can do for you. That's the perception. They kind of forget about you. You're continuously having to remind people that you still require access to services in terms of mobility, physiotherapy, mental health support, pain control, etc., etc. So it is quite a challenging space to have to advocate in, and certainly one of the more difficult spaces in terms of diseases.
Indeed. I mean, 5% of rare diseases having actually a known treatment, that's quite a big thing, considering that you have more than 7,000 of rare diseases.
Correct. So, and I mean, obviously, with the advances that are happening in research and development, etc., we are developing new therapies every day, and new stuff is being found out every single day. But it's quite daunting as a patient. The 5% that have treatments available are generally the very, very progressive and most debilitating conditions. So you kind of have to wish that you've got the bad straw from that perspective to get one of those, because then there's at least a treatment available. But then you must also know that the conditions are completely debilitating. So it's really is a tough place to be as a patient. But again, accessing, just remembering that these patients, even the ones that don't have commercial therapies, are still people and they still need support is critical, for them to feel like they can also do, there's always something positive, a positive intervention that can be made to improve the patient's quality of life. And it's just reminding ourselves that we need to continuously strive, even for the forgotten ones.
Yes, and I think that's the bottom line, right? Improving the quality of life, even when the treatments aren't available. But I mean, what does it mean in the African context? We have trouble making treatments available for even things where treatments are available and they're affordable. And now in rare diseases, we're talking treatments that are available just for a small proportion of diseases. And the ones that are available, they are extremely expensive. And so how do you support patients and their families where they cannot afford the treatment and perhaps the treatment isn't available? What does organizations like yours have to do to support those that don't have access?
Yeah, so I mean, the patient journey is a lengthy and complex one. So first and foremost, patients need support. They need to find a village of people that they feel they can relate to and that they can go to for help and assistance. And I think that that's one of the biggest and easiest interventions that as an organization we can offer, is that peer-to-peer support. So following that, obviously it's assisting patients accessing appropriate research, trying to motivate for them getting access on clinical trials. And then obviously where there are commercial therapies, trying to encourage those countries, those manufacturers, to invest in us as countries and bring their products into our particular countries so that these patients can also be treated. You've rightly identified that Africa is often the forgotten continent in terms of medical intervention. I think it was made quite clear with the COVID vaccines, and we saw how that rolled out and how South Africa, Africa as a continent was left off the list until really last. So we do have, some additional challenges in that regard. And we also have relatively poor infrastructure, logistically. We cover vast areas. Traveling and transporting these products can be difficult. So there's lots of issues around that. But also just in terms of our budgets, we are fighting a lot of other disease burdens and threats, which many other first world countries are not fighting, such as HIV, TB, malaria, and those are very, very big competing healthcare priorities. So, we've got a lot of unique challenges in the African continent that you don't see in other parts of the world that make it even more difficult for us to navigate. But we're also a very, very resilient bunch of people, and we make do with very, very little. And I think we've just, learned to march on, even when things aren't going our way. You kind of just keep going forward because we don't have a choice.
Clearly, you have to make the best of what you have available. And in essence, it sounds as though you, as families that are affected and organizations that have been set up to support people and families with rare diseases, you have to be catalyst for change and to advocate at all levels of a health system, all the way to the development of the treatments that are needed. And so what needs to be done in order to speed up change? Are you seeing the right things happening on the African continent in terms of the changes that you'd like to see to improve the quality of life of people who are affected by rare diseases and their families?
Yeah, certainly, I think we are making progress. I think the speed in which we make progress is sometimes a little bit frustrating because it's long and it's slow. But, to take into example, we've now got an African Alliance for Rare Diseases, which includes 17 different countries. That wasn't there 6 years ago. So, even though when you felt like you were alone as a country, now, you've got friends in other countries in Africa. And whilst we're all at very, very different levels of development in terms of our advocacy policies, etc., we're all there to support and help one another. We've got great referral systems that we've developed as a result of those partnerships. So patients in remote parts of the continent can actually get access to support much easier now than what they could before. I suppose the development of digital modernization has also really assisted us in easing the communication barriers that we used to have, although language still is a problem. And in South Africa, we have 11, official South African languages. So to communicate with patients in a language that is familiar to them, that they understand well, remains challenging. But I certainly think we are moving in the right direction. What we would certainly like to see in Africa is more investment from a government perspective. We are driving 90% of the change, I think 95% of the change. Very often, we're not seeing that capacity come through from a government perspective or a willingness. And we'd also like to obviously see recognition from an African Union perspective, because we know that Africans like to do things our way. So it's not to say what happens on UN level or at the World Health Organization is easily translated into African terms. We really need our own leaders to put their best forward in terms of developing policies that are beneficial to this population.
Now, that's a really great point, the need for governments to invest in this and of course, for recognition at the regional level. And I think it sounds like you've made a lot of progress, an African-wide, a Pan-African organization with 17 countries. And obviously, I'm sure you want to see more countries become a part of that so that you can extend your reach of patients that need the kind of services that you provide. But all of this, of course, you mentioned earlier, it starts with diagnosis, actually identifying the patients. And that requires that you have experts, right? People who are knowledgeable about these diseases, and the extent of knowledge and access to that knowledge varies across the continent. Since you started, right, when your baby was 11 months, how has that evolved? The diagnosis part, the availability of experts who understand these illnesses, and the ability to reach a diagnosis earlier than the 5 to 7 years that is the average.
So I think, at the time my son was diagnosed, a lot of the testing needed to take place overseas still. And that cost is generally a cost that's borne by the patient's family, which is one of the biggest prohibitors in terms of actually getting it confirmed diagnosis, is that people don't have the money to dish it out up front to have those tests done. So we worked really, really hard in terms of lobbying for local expertise and local investments into South African labs who could then facilitate these tests locally. And we've been successful in that. And we now have Northwest University's, the Potchefstroom Human Center for Metabolomics. They are now actually carrying out the tests, many of the rare disease tests, particularly in the metabolic space, that are required. And then once we had that up in place, it was now to develop a reference network in other African countries, which we've done. So we've got testing available in many countries. We have logistics support, etc., available for those neighboring countries to be able to send their tests through at a much cheaper rate than what it was when we were sending it to Europe and to the USA for that testing to be done. So that all gets facilitated in South Africa. One of the big challenges we still have is that Africa as a continent, we have lots of novel variants in terms of our genotyping. So we see lots of genetic mutations that come through that are new to Africa and that we only see in Africa. And so the interpretation of a lot of these molecular tests remains, the expertise to interpret these tests is still something that remains a challenge. And that's certainly what needs to be addressed next in order for us to really move it into the next phase. But I think being able to test for our stuff within our own continent has already made a significant difference. And with the assistance of many sponsors and donors, we've actually managed to get some referral networks in place where we can easily, as an example, a doctor called me 2 weeks ago from Botswana, needing to test 2 patients. And I received notice yesterday from the lab to say that the samples have arrived in South Africa. So just in a matter of 2 weeks, we managed to get them, we managed to get the diagnostics done, whereas before that would take months, if not years.
And so does that mean South Africa has now become the referral center where samples across the continent are sent, or do you have various centers in the different regions?
I think certainly in the SADC regions, I think they are heavily reliant on South African expertise in SADC regions. Up north of Africa, they obviously have very, very good links back into Europe. So a lot of the testing that happens north of Africa is either done in their particular countries like Egypt, Israel, etc., manage and facilitate their own tests. but certainly Southern and a lot of Central Africa does refer back to South Africa. So yeah, absolutely. I think as a country, we've done our bit in terms of trying to mentor our neighboring countries and also use the experience and the expertise that we've managed to get off the ground to benefit those countries as well.
You mentioned the genetic nature characteristic of rare diseases. Over 80% of rare diseases have a non-genetic origin. But what we've seen when you look at genomic research globally, the contribution of people on the African continent, especially those with African ancestry, is very, very low. Pre-pandemic, it was 3%, and in 2021, during the pandemic, it dropped to about 1%. What is the answer to changing this? Because obviously, making treatments available to people who have those unique genetic mutations that you mentioned that are being found in African populations requires that participation, that will increase that number of African contribution from 1% to something, more significant. What needs to be done to change that?
Yeah, so it's a very big problem. So I think most of the studies that are done from a genotyping perspective and a genetic understanding perspective take place with the white European male. That's the kind of prototype. So all the studies, etc., revolve around that. I mean, things like H3 Africa and those sorts of projects have certainly assisted us in getting a better understanding of our genes in Africa. The interpretation, like I mentioned earlier, remains a problem, but you've rightly pushed onto a point. During times of COVID, we relied on air transport to move these samples out. So the testing that takes place outside of Africa, and even within Africa, we're reliant on air transport to move those samples. During COVID, there was no flights coming in and out of Africa for extended periods of time. So actually transportation of those samples was virtually impossible. And that has, resulted in a massive delay in terms of diagnostic availability. So I think, that localized testing certainly is going to kick off. What we'd like to see is, and there are lots of projects that are being undertaken by the likes of Northwest University, where there are training labs across Africa to be able to facilitate those tests as well within their own particular countries, and that will certainly help. But the interpretation of those molecules and of the findings is still where the biggest lap lies, and we need to work on educational programs that develop those expertise for us to be able to not only do our tests locally, but then also analyze and understand what we're finding in those tests, and then obviously publish and report them. And make that information known. So things like localized biobanks are becoming a big thing. We as Rare Diseases South Africa are in the process of developing a localized patient-led registry, and we are doing that alongside Northwest University's biobank, so that people can store their samples for testing at a later stage or for retrospective testing, so that we can get improved data in place to better understand, what happens in the African genome. And we need to work together in order to get that done. It doesn't help doing it in isolation, because we'll end up being the next, white European male from a, typical. We don't want that. We want to understand, in Kenya, this is what we see, in South Africa, this is what we see, in, the southern regions, this is what's more prominent. So, but the developing of the interpretation expertise is really where the massive gap lies at the moment.
If samples are having to be sent to elsewhere for interpretation, for processing, to what extent does that affect the data that is available on the continent that you're gathering as an organization, as a network across the continent? Because that's also critical, right, for improving patient care and standards of care.
So, I mean, if you take for an example, take a lab sitting in Germany as an example. They are obviously their algorithms and their testing algorithms and their computers are set to find things that they find regularly and all the time, right? So you send African samples in there. Very often we miss that there is a mutation available, unless they're doing whole genome sequencing, which is very, very expensive and often not requested. So as a result of that, these patients are getting a report back that states you haven't got this condition, or no genes, no variants were found. When in actual fact, when we do a full gene sequencing, you do find these variants, but because of the fact that they're novel and they haven't been seen by those labs before, they're not picked up on. So that, that leads to half the complication. And this is why biobanking becomes so important, because we are now, once you've determined one new novel variant, you are able to, refer back to patients that had similar symptoms, etc., and retrospectively test those samples that might be sitting in the biobank to see if they certainly had the same variant as well. So, getting that localized data is absolutely critical for our development. And then also, when you look at gene therapy and the targeted therapies that are now becoming the kind of next generation of medicine, is all very much about these nuanced drugs that are developed specifically to fix a particular genetic problem. And in doing that, if we don't have our variants put forward, we're not going to develop methods and mechanisms to treat those particular variants. So we'll be left off, the next set of medicine unless we start getting this testing issue right and the interpretation issue, sorted.
So it sounds like we really need a greater number of institutions getting involved in this, in terms of, expanding the research scope and ability to actually define, I guess, the variants that are typical in African populations, because obviously sending the samples to Europe is not extremely helpful if the systems over there are set up or optimized to detect what is most common in those populations, which is quite different for what we have in African populations. Now, you mentioned biobank as being one of the most critical things to make sure that we maintain that knowledge and be able to extract information in terms of those variants. How are the regulations in terms of permitting, the establishment of biobanks? And because sometimes, at least in medicines, in the African context, that can be quite a challenge, when you're going into these very niche areas where we don't have the systems and expertise established. How do you find the regulatory environment around the biobanking and all of that, the storage of samples?
Yeah, so luckily for me, we only had to input the application process to develop a biobank it's an exceptionally lengthy process. Obviously, lots of different approvals required, and particularly in terms of ethical approval, ensuring that patients have the ability to withdraw from that biobank at any given time, that that the data is not, used for any extortive purposes, etc. Because we have had some issues, particularly in the African context before, where that data has been, hasn't really provided much input back to those communities. So there's certainly, it's an extensive process, and luckily for us, the academic institutions that we work with have been quite successful in terms of getting that up. The regulations behind it, though, are obviously strict and they need to be. So it is quite a lengthy and expensive investment. I think one of the issues is finding investors that are willing to invest in that with very little benefit in the beginning. Long term, we know that there'll be lots of benefits, but investors generally like to see quick return on investment, and unfortunately, rare diseases don't necessarily provide that quick return. So it's really about finding altruistic and philanthropic institutions that are prepared to invest now with very minimal returns in the hopes of a prospective future. And I think that that's one of the difficulties in terms of Africa, is actually finding those investors. But then we also have general problems, like, South Africa sits with load shedding at the moment. We sometimes without power for 10 to 12 hours a day. When you are, dealing with scientific equipment, etc., that requires continuous electrical supply, that becomes a further challenge. Storaging of those samples, transporting of those samples at the right temperatures, all of that stuff lands up becoming an impacting factor. So, sometimes even we get the big things right, and then it's the little things that end up catching you. But like I said earlier, we're a resilient bunch, so we do what we have to. And I'd like to say that, as Africans, we just keep going regardless of what's being thrown in your direction. But yeah, certainly a lot of investments is required in this particular space to ensure that these biobanks remain viable, that we are able to actually get the necessary information that we need out of them, and that we are able to use that information to go on and develop further, mechanisms to give back to the community that's put into those biobanks to begin with.
Who owns the data when you gather it?
Yeah, so our patient registry, the patients remain there. They own their own data. They choose what they are prepared to share and what they aren't prepared to share, and they have the ability to withdraw at any time. I can't say that that is the case for all. I can only speak for what we've done with ours. And the one significant challenge that we've always had with regards to registries and maintenance of registries in South Africa has been this heavy reliance on clinicians to actually provide the data and input the data. In a resource-constrained environment where you have very little, administrative support, it kind of is the make or break point. And often the reasons that registries have previously failed is that there is no dedicated administrative support to maintain the information that's applied to it. So we kind of flipped it a little bit to make that responsibility the patient's responsibility. And we've introduced certain elements within our registry to make sure that patients have the ability to benefit from the registry on a day-to-day basis in terms of other things that are instrumental to improving their quality of life. And by doing that, we're hoping to see a much more robust registry, continue into the future that is regularly updated and information is regularly input into that. But for us, it was very, very important that patients kind of controlled and had the ability to control what information was shared and how much they were sharing, so that they were comfortable with it. We've seen lots of concerns around data and how data gets used in personal and privacy policies, etc. And we see that every day with the likes of Google, with Facebook, etc. You see it all the time. So taking all of that into the account, we felt it was really, really important to leave that power at the hands of our patients.
You've raised so many critical elements. I mean, investment being one of the most important things that you need in order to develop the services that are required, the infrastructure, the laboratories, the experts, and everything that you need to provide the right kind of support to patients. And much of this, in my view, is really a lot to do with strengthening health systems to be able to pick up all range of problems that a patient might present with at the health facility. But with regards to specifically rare diseases, what is the investment case that you have to make in terms of why investors should invest in this? I mean, obviously, every life is important. What is your investment case for rare diseases? Why investors should come and invest?
So I think from a business perspective, I think rare diseases have their low-lying fruits and they have maximum gains that are available to be extrapolated. So we're taking that investment from 0% to 70% to 70% growth, whereas in many other health tech or health technologies, a lot of interventions are already there, and you may be improving things by 2 to 5%. So yeah. That's the one. From a ethical perspective and from an altruistic perspective, rare diseases are growing all the time. And it's because of improved knowledge and improved awareness. But years ago, you might have only ever heard of one child that was impacted by a rare condition. Now, 3 or 4 people whose children have issues or who've got family members who are sick and they can't quite identify the problem. So rare diseases are growing. And from an altruistic perspective, they know no color, no shape, no size, no age. They impact everyone. With 1 in 15 South Africans being impacted by a rare condition, that's one person in every rugby team. So when you look at it like from that perspective, you realize that you might very well be personally impacted tomorrow. So we always say invest today for a better tomorrow. Make the investment now so that when that tomorrow comes, if you're in that tomorrow, that there's already stuff in place to make your journey that much easier. And that would be my pitch. There's so many fantastic causes, and we don't want to take money away from other competing health priorities, etc., because everyone's out there doing fantastic work. But the impact that you can make, the significant difference that you can make to our families and to our patients takes them from a baseline of 0 you're not taking them from 90% to 95. You're taking them from a baseline of 0. So I would say I'd rather take someone off the starting block than just move someone a little bit closer to the finish line.
And of course, the impact is beyond just the one child, one person, individual who's affected by the illness. It's entire families, siblings, parents who have to be caregivers, and what that means for the economy of the family and of course for the community as well. So I guess their social economic impact is a lot greater as well, and that's another reason to invest in them by ministries of health, by the region, at the continental level. Now, talk to me about clinical trials. Obviously, that's really critical to improving patient care, that we have enough patients that are specifically in our African context being involved in the trials of those treatments that are being developed, to see how they can be made to work in this context.
I would love to say clinical trials were readily available for many of us, and they aren't. And it's a really, really sad thing. So I think it will improve as things go, as time goes by. Specifically, for many of the rare disease conditions, new treatments that are becoming available for existing treated conditions, you require patient naive, treatment naive patients. So the patients that get enrolled into the clinical trials need to have not had any intervention previously. For many of the first world countries, they've had something offered to them and they've been on treatment already because they're so much more advanced. So South Africa is really a gold mine in terms of treatment naive patients. However, logistically and from from an administrative perspective, we've got a lot of issues with our healthcare system, and that makes the investment into Africa from a clinical trials perspective difficult. So, feedback loops, if you look back at the, technology infrastructure, availability of localized testing for biomarkers, etc., those things need to be in place to successfully manage clinical trials in South Africa. So I think that's, well, not South Africa alone, but Africa as well. So I think that's one of the difficulties. But we are starting to see a lot more investment within the South African context for clinical trials, because of the fact that they're needing to find these, treatment naive patients, but also because we've managed to successfully make the point that South Africa, Africa as a continent is the forgotten continent. We like the ugly stepchild of the world. And nobody ever wants to invest here. And I think we've managed to successfully make that argument from a moral and ethical imperative that these patients also need to be assisted and have some intervention. So we are starting to see clinical trial offerings trickling through. And we just hope that we can really, really build on that, so that patients that can't access treatments due to affordability or access are still able to participate in research because the clinical trials are available.
It's incredible the amount of progress that is happening, starting from nothing. So I think that's encouraging. But in terms of genomics research going on the ground, on the continent, how has that developed? How is that progressing?
Like things like H3 Africa, those sorts of, projects and pilots, etc. I think definitely there is more understanding in terms of genomics and a willingness. I think what we still battle with is that many people are working in silos and that there isn't good information sharing across the continent, although I think we are getting better than what we were a decade ago. But I think that if we could break down those barriers and everybody work together, research is quite competitive, as you can well imagine. And I think that adds to some of the issues in terms of sharing of information and communication. I also think that Africa as a continent is still relatively far behind in terms of our thinking around acknowledging patients-led expertise and incorporating patients into the research, so really having patient-led research, which is something that we focused on a lot within our organization in South Africa. And I think that, we are starting to see changes being made in that regard, but definitely a lot more development is required in that sense. And then publishing, when you've done the research, you need to share it. And we need to share it in international journals to make them aware of what we're seeing here, because that helps ultimately bring the investment into our area. So yeah, lots of work to be done in that front.
You are definitely not going to be out of work anytime soon.
No, not anytime soon.
Yes, yes. In terms of then the future, where you're headed, can you just talk to us about some of the ideas that you think you would like to see happen going forward? Your call to action in terms of what is needed and where you're at?
Well, I think, as you so rightfully said, there's still lots of work to be done, and we need partners to do it. So we continuously looking for, and that I said it earlier as well, there's always some intervention that can be made, and there's lots of stuff. It doesn't always necessarily need to be monetary. Sometimes it's skills development, sometimes it's investment into infrastructure and IT. So for anybody out there listening who this has, struck a chord with, reach out, get in touch. Partner with us in any which way is possible. There is so much work to be done on our continent as Africa. If developing Africa is your thing, help us develop our networks. If developing infrastructure is your thing, help us develop the infrastructure. There's so much work to be done. We can improve the lives of patients as individuals, as communities, as a collective rare disease group, as a continent, as individual countries. So there's so many different elements of things that need to be done. Research remains a key focus area, but also community development, raising awareness, education, reducing stigma. All of those things still remain high on our priority list, because that all impacts patients' quality of life from a day-to-day perspective as well. So many different touch points to be able to touch, and there's always some partnership to be made. You just got to find what works for both of you.
Kelly du Plessis, CEO of Rare Diseases South Africa, thank you so much for coming on to Utano Podcast.
Thank you so much for having me. Much appreciated.